Hello, I am Jessica T. Cortezo.
I am Natasha Uy. We are going to discuss amyotrophic
Amyotrophic
lateral
lateral
sclerosis
sclerosis,
or Lou
Lou
Gehrig's
Gehrig's
disease.
disease.
Amyotrophic lateral sclerosis, most commonly known as Lou Gehrig's disease, is a progressive degenerative disease involving the motor system. It is named after the baseball player Lou Gehrig who acquired the disease. It commonly occurs at the age of 40 to 60 years old and can either be sporadic and familial. The risk factors for ALS includes genetics, age, sex, lifestyle such as smoking and alcohol, viral infections, environmental and occupational exposures, autoimmune disease, and head trauma. The cause of ALS is unknown. However, the leading theory of researchers suggests that overexcitation of nerve cells by the neurotransmitter glutamate results in cell injury and neuronal degeneration. Cases of ALS can be sporadic, however 5 to 10% of these are familial, which is a result of one parent's autosomal dominant trait. Amyotrophic lateral sclerosis, or most known as Lou Gehrig's disease, is a progressive and fatal neurodegenerative disorder of the upper and lower motor neurons. The patient would manifest symptoms such as muscle weakness and muscle wasting. The non-modifiable risk factors of this condition is genetics, sex, and age. For genetics, while ALS can be sporadic, it can also be familial, with 5% to 10% of these cases is a result of one parent's autosomal dominant trait. Men also have a slightly higher rate of being affected than women, and this condition usually occurs between the ages 40 to 60 years. The modifiable risk factors include lifestyle such as smoking and drinking alcohol, environmental and occupational exposure, viral infections, autoimmune disease, and head trauma. Lifetime of intensive sport or physical exertion and activities increase the risk of acquiring ALS, as observed from veterans who were deployed during the Gulf War, had greater cases of ALS than those who did not serve. Lou Gehrig's disease has an unknown cause, and its neurodegeneration mechanism is multifactorial and operates through interrelated molecular and genetic pathways. The condition is a result from a complex interaction of cytoplasmic protein aggregates, mitochondrial dysfunction, transport defects, cytoskeleton defects, and excitotoxicity, among others. Impaired proteostasis happens when proteins build up in the cytoplasm after not being transported into the nucleus. Failure of the buildup and breakdown of proteins also cause misfolded proteins to accumulate in the cytoplasm, thus aggregating and becoming toxic to the cells. This causes damage to the mitochondria, which leads to oxidative stress that triggers breaks in the DNA and affect DNA repair processes. When DNA is not repaired properly, it contributes to the death of a neuron. The transport system of the cell, such as the endoplasmic reticulum and Golgi apparatus, is also damaged during protein aggregation, which results in the failed transfer of RNA, proteins, and vesicles in the cytoplasm and neuron axon. If vesicles, which carry neurotransmitters, fail to be transported to target cells, the target cells do not receive signals or messages, and muscles will not contract. If the cytoskeleton is damaged, the axons will retract and disconnect from the muscle, which also causes the failure of the muscle to contract and eventually neuronal degeneration. Protein aggregates, or prion propagation, of misfolded proteins from cell to cell explains why the condition spreads from one area of the body to another.
The neural degeneration will also affect several muscles. It includes the leaves, the bulbar areas, the axial muscles, and the respiratory muscles. So the limbs, the control is separated into upper motor neuron and then lower motor neuron. For the upper motor neuron or the upper extremities, upper area, the reflexes are increased, muscle tone is also increased, and there is signs of weakness. For the lower area, the reflexes are decreased, so as the muscle tones, and there are fasciculations, muscle atrophy, and also weakness. So this weakness, the weakness that we see in the patient, the weakness in the limbs would lead to stasis and then complicate to venous thromboembolism. The weakness can be detected by the EMG findings, in which motor units fire signals involuntarily and spontaneously, resulting to fasciculation potentials. And then also in the EMG findings, there is motor unit acute denervation which shows as fibrillation potentials and positive sharp waves. Also, there is could be chronic denervation and innervation that manifests as large amplitude, long duration, and complex motor unit action potentials with neurogenic recruitment. Then also, so going back to the muscles that are affected, we have the bulbar, also separated in the upper and lower. For the upper, there is pseudobulbar affect and also increased jaw reflex. For the lower, there is tongue atrophy, fasciculation, and CN and cranial nerve 12 weakness. This will lead to facial weakness, dysarthria, which we have nasal and or hoarseness speech. We have also cranial number 9 and 10 that shows weak or asymmetric palatal elevation, and also dysphagia, which later on complicates the failure to thrive and aspiration pneumonia. For the axial, for the upper, we have stiffness and imbalance. For the lower, we have extension weakness in the neck and trunk and fasciculation that complicates the falls and use of ambulatory assisted devices. For the respiratory, we only have the upper part. We have tachypnea. The signs and symptoms, we have tachypnea, orthopnea, low speech volume, use of accessory muscle upon breathing, abdominal paradox. We also have morning headache, which all will then complicate the respiratory failure.
At this juncture, we are going to discuss about the diagnostic and laboratory procedures for ALS. First, physical exam. The cranial nerves are checked to identify which motor nerve is losing its function. Then we have deep tendon reflexes. It is done in order to check the reflexes. In ALS, the upper extremities are hyperreflexive, whereas the lower extremities are hyporeflexive. The following are expected by the neurologist to find during the physical exam. First, we have muscle weakness, which is usually on one side of the body. Then we have slurred or slowed speech, as well as other signs of muscle weakness in the mouth and tongue. Then we also have muscle twitches. Muscles that have shrunk in size have unusual reflexes or tight and rigid. Emotional changes are also expected, such as uncontrollable laughing and crying, as well as a loss of good judgment and social skills. Next, we have urine and blood tests. A laboratory analysis of your blood and urine may help the doctor rule out other causes of the symptoms. Also, at times, thyroid function test is also included. Electromyogram or EMG. In this procedure, the doctor inserts the needle electrodes into the muscles. The test measures muscle contraction and relaxation, electrical activity. Abnormalities in muscles seen in an EMG can help doctors diagnose or rule out ALS. An EMG can also help guide your exercise therapy. Then we have magnetic resonance imaging or MRI. The intense magnetic fields and radio waves create detailed images of the brain and spine. It can detect spinal tumors, herniated discs in the neck, and other conditions causing your symptoms. Spinal tap or lumbar puncture. In this procedure, a small needle is inserted between two vertebrae in your lower back to remove a sample of your spinal fluid for laboratory testing. Different substances in your spinal fluid are evaluated to help diagnose brain and spinal cord problems, including ALS. The puncture site is usually between the L3 and L4. And last but not the least, muscle biopsy. A muscle biopsy may be performed if the doctor suspects you have a muscle disease rather than ALS. A small portion of your muscle is removed and sent to a lab for analysis. This procedure is done under local anesthesia. And now, we are going to discuss about the treatment. Actually, there are no specific treatments that are designated for ALS or Lou Gehrig's disease. Most of the medications has supportive roles only, or only helps to manage the symptoms. There are two medications suggested for ALS. First, we have Riluzole under the brand name Rilutech. It is an oral medication that is thought to reduce motor neuron damage by lowering glutamate levels, which transport messages between nerve cells and motor neurons. Riluzole prolongs survival in people with ALS by a few months in clinical trials, especially in the bulbar form of the disease. Individuals who have trouble swallowing may prefer the thickened form called Tiglutic or the on-the-tongue tablet Exservan. Then we have Edaravone under the brand name Radicava. It is given by intravenous infusion and has been shown to slow the decline in clinical assessment of daily functioning in persons with ALS. Physicians may also prescribe medications that will help in managing symptoms of ALS like pseudobulbar affect, like involuntary or uncontrollable crying, laughing, or other emotional displays, which can also be treated with medications. Pain, depression, sleep disturbances, and constipation can all be treated with drugs. There are other treatments or therapy that could be done to help in managing ALS. First, we have physical therapy. This is to help the patient or the client stay mobile. It can ease discomfort from stiff muscles, cramps, and fluid retention. Then we have nutritional counseling. It ensures the client to eat a healthy, balanced diet. A nutritionist can also recommend other food options when swallowing becomes difficult. Then we have speech therapy, which provides strategies for safer swallowing and communication training to help client maintain verbal communication for as long as possible. Client may also learn nonverbal communication techniques. Client may also use assistive devices, including splints, braces, grab bars, and reach devices that helps them to stay independent. They can use these devices to get dressed, eat, use the toilet, and bath. Also, like Stephen Hawking, they can use special equipments such as wheelchairs and electric beds to help them function independently. And now we are going to discuss about the possible nursing diagnosis for ALS. First, we have impaired physical movement may be related to muscle wasting, weakness, and is possibly evidenced by impaired coordination, limited range of motion, and impaired purposeful movement. Then we have ineffective breathing pattern or impaired spontaneous ventilation that may be related to neuromuscular impairment, decreased energy, fatigue, tracheobronchial obstruction, and possibly evidenced by shortness of breath, fremitus, respiratory depth changes, and reduced vital capacity. Then we have impaired swallowing, which may be related to associated condition of neurological problem and possibly evidenced by delayed or repetitive swallowing, coughing, choking, and recurrent pulmonary infection. Then we also have powerlessness. This may be related to chronic and debilitating nature of illness, lack of control over outcome, and is possibly evidenced by expressions of frustration about inability to care for self and depression over physical deterioration. Grieving is also one of the nursing diagnoses. It may be related to alteration in the neuroendocrine function with potential loss of self and psychosocial well-being. This is possibly evidenced by sorrow, choked feelings, expression of distress, changes in eating habits, sleeping patterns, and altered communication patterns or libido. Then we have impaired verbal communication that may be related to physical barrier or neuromuscular impairment and is possibly evidenced by impaired articulation, inability to speak in sentences, and use of nonverbal cues like changes in facial expression. Now we are done to the nursing interventions. The main focus of nursing management is in improving or maintaining the function, well-being, and quality of life of the patient. For the first intervention, we have provide intellectual stimulating activities. This is because the client is typically experiences no cognitive deficits and retains mental abilities. Then we have provide client and family teaching. This is to educate them about the disease process and what they have to do. This could also help them reduce their anxiety. Then we have promote measures to enhance body image. This boosts the client's confidence and help them feel better about themselves. We also have to promote client and family coping as the client and his family or her family deal with the poor prognosis and the grieving process. In times like this, support from client's family is highly needed so that the client will feel better and they will not feel alone. The nurse might also provide referrals. Clients may be referred to a physical therapist and nutritionist to help them manage the muscle weakness. The client or the patient is also advised to maximize functional abilities. This is to prevent the complication of immobility like ulceration and also to promote self-care. They are also advised to maximize effective communication. However, clients with ALS has problems in communicating or speaking. The nurse may ask them to point or look at the letters which spells out the things that they want to say or ask. If they can afford it, they may use the same thing like Stephen Hawking's wheelchair, where it is connected to his brain and the machine speaks for him. Also, you have to ensure the client's adequate nutrition. And last but not the least, we have to prevent respiratory complication. To do this, we have to promote measures to maintain adequate airway, such as coughing or breathing exercises. We also have to promote measures to enhance gas exchange, such as oxygen therapy and ventilator assistance. Also, we have to promote measures to prevent respiratory infection. That ends our presentation for today. We hope that you learned something about ALS or amyotrophic lateral sclerosis, or also known as Lou Gehrig's disease. Thank you so much for watching. Have a great day!